So this is part 5, the last part of the lecture, on intravenous solutions. There's a number of reasons we give IV solutions: to hydrate the cells, to maintain the blood pressure, to correct any kind of fluid shift problems that are going on, and to deliver medications and deliver nutrients. But the primary reason is to hydrate the cells. We want to get water into the cells. That's the usual reason that we give IV fluids. Now, one thing we never give into the vein is pure sterile water. We give some mixture of saline or dextrose, but never pure water, which is what the cells are wanting. The reason why is because of the red blood cells in the bloodstream. So here's a vein, and say that we put in an IV catheter. There we go, an IV catheter. They look just like that. And then the solution is coming into the bloodstream. What happens in this situation is the pure water gets soaked up by the red blood cells that are adjacent to this IV catheter, and the red blood cells simply have no stopping. They swell up with water until the point that they burst. They lyse. And that's why we can't give sterile water IV. Every IV you give will either have some component of dextrose or saline, and the only time you ever really give sterile water is if it's mixed with a medication. All IV solutions are either crystalloids or they're colloids. The crystalloids are the ones that you see in the hospital most of the time. It's that bag of clear fluid, and those are subdivided into isotonic, hypotonic, and hypertonic, comparing their tonicity to the bloodstream. The other kind of IV solution are the colloids. These are thick solutions. They're volume expanders, essentially. The real definition between the two that changes them is that the crystalloid is a solution that can be diffused through a cell membrane, and a colloid is a solution that cannot be diffused through a cell membrane. And we'll talk more about them in a minute. So first let's talk about the isotonic solutions. So we're on the crystalloids, we're talking about isotonics. Isotonic solutions have the same concentration of solutes as the plasma. So they will not change the tonicity of the plasma. So there's no real reason for any water from the cell to try and come over to the extracellular space because it's the same tonicity. So what happens with isotonic solutions is the fluid that we give tends to stay in the extravascular space. So we use the isotonic solutions to build up vascular volume when we want to tank up the bloodstream. And an example of that would be normal saline. Normal saline is an isotonic IV solution. Lactated Ringer's is another one. So when you give the isotonic IV solutions, you need to watch out for hypervolemia because it's possible to overwhelm the bloodstream with these. Hypotonic solutions will make the fluid in the extracellular space hypotonic once they're added to it. So there's a lesser concentration of solids than the plasma originally had. So now the extracellular space has less concentration of solids than the cell. So what happens is, because of osmosis, water tries to equalize everything out. Here we go. And so the effect of giving someone a hypotonic solution is that free water from the extracellular space will enter the cell. So we give the hypotonic solution when that's what we want to do, to hydrate the tissue cells. An example of a hypotonic solution would be D5W, once it's been in the body for a short while, or half normal saline. So what you want to do for these, the patients you have to watch out for when you give a hypotonic solution is anyone who has a third space shift. Remember the patient with ascites who had the large belly, because that fluid will just keep pouring into those transcellular spaces. Also someone who has increased intracranial pressure, you'll be pushing extra fluid into their brain cells, and that could be disastrous. But the hypotonic solutions in general are used to hydrate the tissue cells. The hypertonic solutions have a greater concentration of solids than the plasma. So once they go into the extracellular fluid, into the bloodstream, they make it very hypertonic. So what's going to happen in this situation is fluid is now going to leave the cells through osmosis to try to equal that out. The effect is to draw fluid from the cells. And then we sometimes give it for that reason. We sometimes give it when we're trying to pull fluid out of the cells if we think the fluids are overhydrated, or edema, forget edema. I missed a boat. We don't give these for edema so much. But if we think that the cells are overly hydrated, we can pull fluid out that way. A more common reason that we give these is because they have such a high concentration of saline or dextrose. We do it to raise serum sodium or glucose if the level is low. Pardon me. So for this particular patient who's getting the hypertonic solutions, it's very important, obviously, to watch for signs of hypervolemia, because you could really flood the extracellular fluid area, extracellular space. You could really overwhelm it with fluid. And also, anytime you raise someone's blood sodium, you have to be very, very careful, because you can send them into sort of a central nervous system reaction where the brains and the cells can't handle that rapid shift. So we don't give the hypertonic solutions to any patient who's dehydrated, obviously, in their cells, because they will simply lose more water. We don't give it to anyone who has kidney or heart disease, because the extracellular fluid could get overwhelmed and the kidneys or the heart will not be able to process that, and they could go into a failure situation. An example of a hypertonic solution is 3.0% normal, 3.0% sodium chloride. Regular isotonic normal saline is 0.9%. That's isotonic, not hypertonic. And then some electrolyte solutions, some crystalloid solutions also have electrolytes added to them. This is an example here. This order would be normal saline with 40 milliequivalents of potassium chloride. And that's when we want to prevent or treat an electrolyte depletion. Anytime you have a patient that's getting a bag of solution that has electrolytes added to it, obviously you need to monitor certain labs. In this situation, if I asked you which lab you would monitor, hopefully you'd know, of course, that you would be monitoring the potassium for this patient. Of course, you'd also be monitoring the saline, or rather the sodium and the chloride that's in the saline, and the chloride here. So anytime a patient gets an electrolyte solution, there's a lot of labs that you need to be looking at. And then finally we have the colloid solutions. The colloid solutions are sticky, glutinous, very large molecules, so they stay in the blood vessels. And we use these to increase blood volume after a serious loss of blood or plasma. And these are three examples I just wrote down: dextrin, albumin, and plasma. These are all things which are given to people basically to tank up their bloodstream. You're going to learn more about the colloids in second year when you talk about resuscitation situations. How the various IV solutions disperse between these compartments, it's not just whether they're isotonic, hypertonic, hypotonic, but also whether they're dextrose or saline based. Because just the water portion of it, for the hypotonic solutions, that goes everywhere. Water goes into the cell, it goes in the interstitium, it's in the bloodstream. Same thing with dextrose. If it's a dextrose solution, that will tend to often go just about everywhere once it gets down to a hypotonic state. Most dextrose solutions will become hypotonic, and I'll explain why in just a minute. The saline tends to stay in these two and not get into the cell because of the sodium-potassium pump. So now let's talk about the various IV solutions and how that plays out. 5% dextrose in water, no one's ever going to call it that in the hospital. They're going to refer to it as D5W. And that is isotonic in the bag. Your article by David brought this up, but that really doesn't matter. What matters is what's in the body, of course. Once 5% dextrose, or D5W, gets into the body, the pancreas, when it senses that sugar, is going to start releasing some insulin, and the dextrose is going to start getting used up. And very quickly it becomes a hypotonic solution that can travel from the vasculature, the interstitial, and into the cell. 10% dextrose in sterile water, no one ever calls it that. They call it D10. We don't give this very often. It's hypertonic in the bloodstream because of all that sugar. Eventually, the pancreas will send out enough insulin that it breaks down to becoming hypotonic. But for most of its ride, D10 is hypertonic. We give D10 if we're trying to maintain a high blood sugar, if we think that someone's going to have hypoglycemia over a period of time. For example, someone who got too much long-acting insulin. That would be one example of when we give it. But generally we don't give, you won't see D10 used very often. 0.9 sodium chloride, 0.9, that's called and written as normal saline. It's one of our most common solutions. That's isotonic. That fluid will not be going into the cell. That sodium and water that's bonded to it will be staying in the vasculature and the interstitium. So this is one we use often to keep someone's blood pressure up, and often if over time we want to keep their sodium level up as well, if their sodium is low. But mostly we give this just so we maintain a good blood pressure on someone. Half normal saline, it's called half normal saline not because there's half as much in the bag, but because the concentration is half. 0.45 is half of 0.9. This is hypotonic, of course, so some of that water will disassociate and go into the cells. So this eventually will go into all three compartments. Lactated ringers, and people just refer to as LR, it is a combination of a number of electrolytes and sodium, and it will stay in the bloodstream or in the interstitial space. The lactate component keeps people from going acidotic because that's a reversal agent for acidosis. This is the most common solution given post-op. Your patients coming back from surgery very likely will have this running. Now these three solutions are a combination of dextrose and saline, or dextrose and lactated ringers, D5NS, D5-half-NS, and D5LR. They're hypertonic in the bag, but the sugar part is going to get eaten up, of course, because it's only D5. It's going to get eaten up by the pancreas. It will send out insulin and the dextrose will go away.